Good afternoon. I'm David Hepner. I'm very, very impressed with the attendance. I didn't even know, does the meeting go till 2 or 4? I don't know. What time is the last session today? Oh my God, you guys are the hardcore. This is unbelievable. So actually, we'll do this 1 to 3 because I didn't have anywhere else to go until 3 p.m. How about you? What time is your flight? But I'm here with my colleagues, and I'll introduce them as I put your slides. Jake Schaaf, which is going to be talking about preoperative stress testing, and then Rebecca Gerlach is also going to be talking about preoperative echocardiogram. I'm going to be talking about preoperative EKG, and we're not both, all three of us are going to review the data and the ACC AHA guidelines from 2024, which is just last year. They cover a lot of. So we're all talking about the part of the guidelines that refer to our areas. But this is me, David Hepner. I'm Mass General Brigham. I'm on the B side. We like the joke when this started. Not only we only have one out of the 3 letters, but we're the last letter. But that's okay. Mass General Brigham. And then I do have some disclosures, but absolutely nothing to do with this lecture. So I call it, as I mentioned, I'm talking about EKG. I'll call it a problem because I think we ordered too many, and they could lead to complications. I'll also discuss what are the implications, what are the limitations of the testing, what are the implications of having the abnormalities, and who are the patients that may benefit from getting an EKG. So it is usually obtained on protocol. I think we're doing much better. Actually, for those that went to a Severing-House lecture today, it was a good slide. I took a picture. It usually takes 12 to 18 years to implement the guidelines. So maybe by 24, 34, by 42, people will be following the 2024, and by that time, we'll have new guidelines. So it takes a long time for people to implement guidelines. This number of 30 billion, it's an old number. It's probably 40 or 50 billion dollars now. And I'm going to show you a study that we did. Are abnormalities more likely the older you are? Yes, but there's not data that it leads to more complications, especially if you're asymptomatic. Doing the DASI is a good test. I'm not getting into the DASI, but getting a good history and see how active they are, it's pretty good. And very rarely do they alter the surgical or the anesthetic plan. So let's talk a little bit about the limitations. And I get this all the time. Oh, if I don't do it, I'm going to get sued if something goes wrong. And my answer usually is, you're more at risk by getting a test that it's not indicated, and not you do it, there are T-wave depressions, oh fine, I'm still going to do the case. If there's a complication, you're probably more at risk of a medical legal than if you do not get it after my lecture, following the guidelines. If there's a reason not to get it, don't get it. It is expensive. It does bring a new risk. Then they're going to do a stress test, which you could actually probably just do. I don't know if, Jake, you're probably talking about the NT-proBNP, which I think we should be doing less and less and less and less stress tests. But it's a new risk for the people that don't know the guidelines. Anxiety-provoking. I talk to patients all the time. I booked the surgery, I have my mother-in-law flying from Illinois, and you cannot postpone my case. So they're very anxious, and it's pretty inconvenient. So misleading, believe it or not, we actually published this. The lead placement does matter. This was on JCA Advances with my colleagues Angela Better, Richard Ehrman when he was with us, Julie Roth, she's a senior resident, now she's a fellow in pediatric anesthesia. But it does matter. And I'll give you a few examples. These are real cases, 65-year-old, insulin-dependent diabetes, going for a gastric bypass, so the BMI was elevated. I think it was something like 45, not active. And it appears what we call poor R-wave progression. So the machine is going to read it as an anterior MI, but or interceptal infarct. But what next? You could just change the order. of the leads, sort of put them probably more lateral. And then what ends up happening is that then there's a nice R wave progression. So you get fixed of the reading of the machine, which probably should not be done by anesthesiologists, but many do it without interpreting the EKG. I prefer to interpret my own EKGs. This is one with Q waves. It's a 66-year-old elective total hip replacement, takes beta blockers, hypertension, high cholesterol. Nothing important on the physical exam, and you could actually see the errors with the Q waves on 2, 3, and F. And as you could see here, with deep inspiration, they actually go away. Why is that good? It's good because 80% of the times it goes away, so it's pretty good. And also because if they persist, it's actually predictive of, so EKG inferior Q waves persistence during deep inspiration is a simple test with a high accuracy for diagnosis of a silent MI. So if it doesn't go away, we probably should take that into account and treat the patients differently, or perhaps do different testing. This comes back all the time. Right bundle branch block, you should be able to read ischemia, but occasionally it may be difficult, but it has a lower prior probability of finding something that will impact management if it is old or if new. The impact of a left bundle branch block, it's unclear. A lot of people don't know what to do. It may be a marker for cardiovascular dysfunction. You could not read ischemia if you have a left bundle. And the guidelines are silent, because the question is, I get that question all the time. I have a left bundle, we didn't have an EKG for the last 10 years, but you're active. Let's say they have like a DASI or 40 or 50. I personally would proceed. If I'm in doubt, I may do an NT pro BNP, and if it's less than 300, I'll proceed. But the new guidelines really don't mention that you do not need to work up left bundle with an excellent functional status. So let's talk about the indications, what I believe are strong indications. Obviously, if there's anything from the history or physical, obvious, like you're not doing it, this is not screening, you're doing it because you have an indication to do it. Type of surgery, as you're going to see, it's for high-risk surgery. The ACC AHA tells you it's always something you could consider. You could consider getting an EKG, but not healthy patients, not minimally invasive procedures, not recent testing. I started lecturing on this, I don't know, this was one of my first areas of interest, like, I don't know, 20, 25 years ago. And when I was preparing this lecture a long, long time ago, I came with this from the pathology literature, but this is what I call the Kepner's rule, since I found this stuff. Like any test, I know we're not talking about pregnancy, but the pregnancy test is a pretty good test. It's either positive or negative, the beta HCG. You're pregnant or not pregnant, it changes the diagnosis. Who here, I'm curious, who here would do an elective case on someone pregnant in the first trimester? So, and does it change the outcome? Maybe. So it's a darn good, any test that have 3 or 4 of these is a good test. Let's talk about an EKG. Does it identify the abnormality? Sure, like a bundle. But does it change your diagnosis? No. Management? No. Outcome? So it's not a good test. It's really not a good test. So what's the rule is do get a good history. Obviously, if the patient has known CAD, you're having major surgery. There's actually data to demonstrate that ST depression, tachycardia are predictors of morbidity and mortality. But again, you're doing it on high-risk patients having high-risk surgery. And it's independent of clinic findings and independent of ischemia. This is a work we did about 15 years ago. Darren Correll, now he saw the light and he's with Vertex, he's in industry, but a lot of people are still doing anesthesia, like Angela, Lawrence, me. And what we did is we were trying to find out, is there an age? Because people were fixated on an age. Like you should do it at 40, we should do it at 50. A lot of the people that use the 65, they're using this. And basically what we found out is that patients that were more than 65, they were more likely to have an abnormal EKG. And we define abnormal as left bundle, T-wave and ST depressions, like persistent Q waves despite of moving the leads or deep inspiration. But there was an editorial, so I'm proud to say that there was an editorial, meaning that, here I'll go back, meaning that it was a good article, but the editorial pointed out that we did not have enough power to look at complications. So if you're just looking, is the EKG more likely to be abnormal? Yes, when you're 65, but we did not have enough power to look at complications. And I'll tell you in a second how I use age personally. The ACA practice advisory or the ACC AHA guidelines don't have age. I have something to say, something good and bad about this. So this is the old practice advisory for pre-anesthesia evaluation from 2012. And they're silent. They acknowledge their study. They say no consensus regarding minimal age. Abnormalities are higher in older patients, and take into account cardiac risk factor, respiratory. But I think what they decided to do is they probably said, let Hepner lecture and instruct all of the ASA members. But just to give you an idea of how much this field has advanced, preoperative medicine, pre-op medicine, is we are actually in the process of revising the practice advisory for pre-anesthesia evaluation. It's not going to mention EKG at all. It's not going to be mentioning labs. We're going to concentrate on anemia, frailty, nutrition, A1C. So I think they say, we're past this. I think we really know that we should not be getting. We don't feel that we need to emphasize it. The one from 2012 at that time, I think I wasn't part of that one, but it was felt that we needed to do that. This is a very, very good guideline. It truly is. I joked, I'm like, maybe I don't have too many hobbies, but the first weekend that it came out, I read it from beginning to end. It says a lot of what, if you practice pre-op, peri-op, it even has an intra-op section, and post-op, it is a really good guideline. And this is the way I interpret it, because I think it's important for you to know the colors. I basically call green and yellow something you should do. Green basically says, do it. There are good studies, there's good data, that there's supporting evidence that you should do it. Yellow means that it's reasonable. It just means the studies may not be as strong, but it's reasonable to do it. The benefit is greater than the risk. Not as good with the green, but that top square, do it. The middle one, that's where EKGs fall. The EKG tells you you could consider it. So you could consider doing it, and we'll talk about that orange. And then the bottom, which is dark orange and red, tells you do not do it, because the risk is either equal or greater than the benefit. So don't do the dark orange or the red. Do the green and the yellow, and the orange. Let's talk a little bit about the orange, the intermediate group for EKG. So they do tell us, this is all from the guidelines. They do tell us the concerning things it's obviously STD pressure elevation, T-wave abnormalities, LVH. I spoke to Anne-Marie Thompson, which is the lead author, Bobby G. Schweitzer, which is one of the authors, Gina Blitz, who was one of the reviewers. And the LVH, they're talking about pretty severe LVH, that it's causing a lot of ST and T-wave abnormalities, not like some minor LVH read on the EKG. Significant pathologic Q waves, we discussed that already. Mobitz type 2 or higher AV block. Bundle-Branch block, I think they're referring more to left. QT prolongation and AFib. And what do they tell us? They say, is this elevated risk surgery? So even when they say there's low, intermediate, and high risk surgery, they concentrate on elevated, and they call high and intermediate as elevated risk surgery. So if it's elevated risk surgery and you have risk factors, do an EKG. It's yellow. So it's in the top graph. Do it. But where a lot fall is in the intermediate and high risk surgery. They're having a hip. They're having like a 2 or 3 level back surgery. They're having a colectomy. So that's going to be elevated risk surgery. And most patients are not going to have CAD, arrhythmias, PAD, and they leave it as an orange. So I loosely use age. If I have like a 70-year-old that doesn't do much, I make it an EKG. I have a 70-year-old that it's a runner. I won't do it. I have a 55-year-old that doesn't do anything. They're like obese, like eating like whatever potatoes all the time, like whatever, and watching football. In that one, I may do it. So I use age loosely, but not just age, but also frailty, the activity, the DASI, just because the ACC AHA is letting me interpret it. Like, if you fall in the middle group, I think it's you could consider it, but you need to take many things into account. And they obviously tell you, even if it is a high or intermediate risk surgery, I'm sorry, if it is not a high or intermediate, if it's a low risk surgery, do not do it, regardless of risk factors, regardless of activity, because the risk is greater than the benefit. So don't do it. Don't do it for the low risk surgeries. Choosing wisely. This is even older. This is from the American Board of Internal Medicine. They basically challenge all major societies to come with 5 things that were done too often, they were expensive, there was no benefit, and there was a risk on doing them. And what did the American College of Cardiology chose? Doing an EKG in patients with a low preoperative risk, having low-risk surgery, just because there's no data. So avoid performing a routine EKG as part of pre-op for asymptomatic patients having low-risk surgical procedures. Actually, I don't know if Jake is going to mention that, but the ASA actually chose 5, and one was stress tests in patients having low-risk surgeries regardless. So that's not my topic, but there's also, this is ACC, but out of the 5 that the ASA chose, 2 have to do with labs or EKG. The other one has to do with lab testing and like asymptomatic patients having low-risk procedures too. So what would I recommend? It is not indicated routinely. Regardless of age, regardless of procedure, it should not be done routinely. Timing, that is another one. I tend to use like a loose 3 to 6 months, but again, I have a runner. That's another question I have tried to ask the authors of these ACC guidelines. I think you could do a gestalt. I tend to do 3 to 6 if nothing has changed, but I think you could consider many different age ranges. Do the history and the physical. Type of surgery may affect the testing, as the ACC guidelines tell us. Age is controversial. Yes, it's more likely to be abnormal, but it's not predictive of complications. And where you have to do, like ours, we're centralized pre-op clinic in the sense that we have our own guidelines, and like the surgeons and the PCP and the hospitalists defer to us. Having said that, I often get a patient having surgery in 2 weeks, and then I find like an EKG from 3 months ago. So if there's an EKG, you probably should read it and see if there's anything concerning, because many times I just happen to have it, but I would say I get it in a very, very small minority of patients. What do the ACC guidelines? Pre-op 12-lead EKG, no data that it leads to improved post-op death, no data that ability to predict MI. Obviously, it could diagnose it, but it could not predict it. Uncertain value. And eliminating routine testing may avoid a cascade of subsequent diagnostic testing. In summary, the resting EKG contains prognostic information related to long-term morbidity and mortality in patients with known CAD. As a baseline, I get that question all the time. Sure, you have a 55-year-old going for a thoracic case and a lot of them going to AFib, and you don't have a recent EKG, probably reasonable to get one. So occasionally you may want a baseline. Do use it selectively, and think about that graph that I had, like whatever it does. Like, is there, and this actually should apply not just for EKG, for stress tests, for getting a consult, for an echo. What are you going to do if it comes back abnormal? Do you have a backup plan? Like, what is the plan? Is it going to change your management? Q&As are at the end of the session. Maybe I should come back to this slide, to the next slide later. But if you like a lot of the pre-op, take a picture of this. We're having a meeting in Austin at the end of February. It's the Preoperative Medicine Summit. As I mentioned, I'm pretty active. All of us, many of the people in this room are pretty active on SPAC. It will be an outstanding meeting. But now let me turn over to check. How do I get it? Do I close this, Jack? Probably. I think I closed it. Oh, back. It's fine. I'm back. So Jacob, start. Jacob Schaff, who is it's a dude. Yeah, he's the chief of cardiac anesthesia at White Plains Hospital, member of the Montefiore. Oh, good. My daughter is at Einstein. We need to talk about it. The North American Partners in Anesthesia, the NAPA, and he's also very active. He has done a lot of work on preoperative assessment, perioperative medicine, very involved also with SPACI and the ACA. So thank you, Jake.
Perfect. Thank you, David. Let's see. We're using the mouse to.
Yeah.
Okay. Oh, the clicker. I see. Down here.
Yeah. I think the way I was doing it is like, you said like.
There we go.
Yeah,
there we go.
Or like this. Yeah.
Okay. So we've been waiting a long time for these, and last year was kind of the first year we got to start diving into it. We've gotten to live with these for a year, so we're going to share some experiences of kind of how we're utilizing these new guidelines. So we'll take a look at some major differences. We'll review some risk stratification tools. We'll talk about functional capacity and how that helps us tremendously with informing us about further cardiac testing. We'll explore some of the risk and benefits to stress testing, and then how to put this all together and how we're managing our patient. So in 2014 was the prior version. You can see really what these guidelines aim to ultimately address was, do you need a stress test? Do you need a stress test before a patient goes to the OR for non-cardiac surgery? And the 2024 guidelines, you can see, gets a little bit more complicated. And I would argue that it's actually more nuanced and in a good way. These guidelines were written in a very thoughtful way that helps support, I think, a lot of our clinical decision making. One thing that I think is very important, that if you have a patient that you're evaluating either in the pre-op clinic or even the morning of surgery, if these patients need evaluation and treatment independent of the surgery, that's something you should do. You don't have to go down these guidelines. So some patients just don't have great longitudinal medical care. And so if we can use this as an opportunity and time to help intervene on their behalf, I think that's something that is important to remember. So if it needs to be done irrespective of the surgery, just do it anyway. You don't have to worry about the guidelines. But what we're kind of talking about is using these as a tool or a screening tool and what we need for evaluation. So let's dive in. So at the beginning, if it's an emergency surgery, you just go. You do the best you can, no major changes there. If the patient's having acute coronary syndrome, don't do the surgery. Again, not too surprising, no deviations from the prior. And then risk assessment. And this is where I think one of the very nuanced and notable changes is. So we're still going to be using our risk stratification tools, which we'll go through in a minute. Those haven't changed significantly, but what they do add are these risk modifiers. And these are all things that we know make patients sick, right? Severe pulmonary hypertension, complex congenital heart disease, patients that have an ICD, like they earn that for some reason, right? So all of these things are harbingers a little bit of something else going on with the patient, where our traditional risk stratification tools may miss some of these things. So I really like that they put these in there as kind of a way to red flag things and say, if your patient meets any of these criteria, we have more work to do. Which risk calculators? They don't specifically say you have to use any particular risk calculator. 3 of the most common, though, that we use are the RCRI, Revised Cardiac Risk Index, the Gupta score, the MICA score, and the ACS NSQIP calculator. These are 3, I think, of the most common ones that are used. So the RCRI is 6 different data points which go into making up a score. It was validated for patients greater than 50 years of age with an expected hospital stay of 2 days or greater. And this is really important when you're thinking about who you're applying it to. So someone having a carpal tunnel surgery, this isn't a great tool for because it wasn't validated in that subset of population. The MICA score and the ACS NSQIP, these come from the NSQIP database, very data rich, which is great. They both have limitations as well. Sometimes the Gupta score, the procedural specificity is not super great, so you get some variation from that. And then the ACS NSQIP is actually a really great calculator. It just takes time, okay? You have to put a lot of data points in. You do get a lot more than just cardiac risk assessment out. You get some pulmonary risk assessment, discharge, wound infections, and so it's a really powerful tool. It just takes more resources to power that. And if you are doing these risk assessments, you may pop up MD Calc or other online calculators, and you'll see that for the RCRI of 0, it now lists a risk estimate of 3.9%. And when you talk about the traditional elevated risk, meaning greater than 1%, like Dr. Heppner was talking about, that means everybody is high risk, right? Well, again, this risk calculator was made before the era of troponin. So these pooled risk estimates have been updated since the era of high sensitivity troponins, which has changed this. So it doesn't mean that it's not a good tool. It's just we have to use it in the context of the ACC AHA guidelines, how it originally was intended, meaning scores of 0 or 1 typically bucket you into the low risk, and then 2 or greater bucket you into the high risk. All of these calculators you have to use take with a grain of salt. So again, and you have to use them the way that they were validated. So for instance, you have a patient with a stent who had a stroke 6 years ago taking insulin for diabetes. This is not an uncommon thing that you may see for a patient having a cataract. 11% of those patients aren't having severe heart failure, MI, or death after their cataract surgery, right? So these are, you have to make sure that you're using it for the right purpose. And similarly, an 85-year-old with suprasystemic pulmonary hypertension having a radical cystectomy for bladder cancer, 0.8%. That's a low-risk patient. That clearly doesn't pass the mustard. And that's where some of these additional risk stratification that the ACC and AHA added, I think are really helpful. So now that you have determined risk, where do you go from there? So if you have elevated risk but no modifiers, that kind of leads you down to that orange box that Dr. Heppner was talking about. If you have any risk modifier with any calculated risk, that takes you to this right-handed side where basically it says take a team-based approach and consider echo, which I'm obviously not going to talk about right now. Both of those things then funnel to functional capacity. So that's what we have to do next, is determine functional capacity. Basically, how do they get around? What's their exercise tolerance? And Dr. Vijay Sundara looked at this with the MET study, and we ask patients this all the time, right? Can you climb up a flight of stairs? The reality, though, is that wasn't really predictive of any outcome. So we have to do a little bit better, ideally upstream at our pre-op clinics. The Duke Activity Status Index, or DASI, is a really powerful tool, and they've actually incorporated that into these guidelines. So anything under 34 is considered a low functional capacity. And then traditional METS assessment as well is another tool that you can use. So now that you've assessed functional capacity, the next step you have to do that is new to these guidelines compared to the old ones is considering biomarkers. So the BNP or NT-proBNP, these are both slightly favored over pre-op troponins and can help with risk stratifying patients further. So you will see these being ordered and coming up a lot more. It's not always appropriate, but it's something you're going to have to deal with. So it's worth having, I guess, a game plan going in as to what values you're going to consider normal, work with your lab, work with your pre-op clinic, work with your surgeons to try to hash that out. So compared to 2014, in 2024 land, if you have cardiovascular risk factors and you have an elevated peri-op risk, and you have poor functional status, and you have abnormal biomarkers, and it will change management. You have to have all of these, and then you can consider a coronary CTA or a stress test. So you can see that the level of where things are going, where the ACC AHA and our national societies, where things are going, right? The bar for having to do a stress test to clear a patient is essentially not there anymore. Like, they are more or less telling you you don't need to do it unless it's very specifically going to change management. Why is that? Well, because adding stress tests to the traditional assessment of meds plus risk stratification doesn't really change or help you that much more. You can see here where in this study, 18 patients had a post-op MI. Half of them had stress testing before and half of them didn't. The ones that did, half of them were negative, meaning these patients still had an MI even though they had a stress test and it was negative, and half of them were positive and we just did the case anyway. So you can see how it doesn't really help guide our management that much, and we have to be really careful about when we order it. And why is that? Well, stress testing really is only going to help us sort out and identify the type 2. So this is like demand ischemia. Heart rate goes up, myocardial consumption goes up, you get demand ischemia. But the type 1 stress plaque rupture, this is not going to be detected. So these lesions might be 40, 50%, which is not going to show up on a traditional stress test. And even if you get a coronary CTA that demonstrates this, no interventional cardiologist is going to go after it. So again, you really have to make sure you know what you're going after. Because the reason they're not going to go after it is there's no good evidence to go after it. Basically, you have to have a severe left main disease to have even, that's a 2A. That's not even a slam dunk to go after prior to elective non-cardiac surgery. And for patients with non-left main coronary disease, it is a class 3 recommendation, no benefit, do not do it. And the best data we have from this comes from the CARP trial back in 2004. So it's a little dated, but it looked at this question for patients undergoing, and not just non-cardiac surgery, but major vascular surgery. And the only patients that did a little bit better with revascularization were the left main and very, very low EF, like under 20%. So it's a very small subset of patients with coronary disease that really should be revascularized before non-cardiac surgery. And why is that? It's because PCIs have risk, right? They have to be, there is mortality risk with that. There's dissections, you can have urgent CABG, there's acute thrombosis risk, and they have to be on blood thinners. There are risk of delaying cancer operations. And so it's really not as clear-cut as it seems. So, this is the way that we used to think about things. Let's get a stress test, let's see if it's positive, and then let's cancel and send them to the cardiologist. And I think really what we need to do is take a step back and try to look at the bigger picture. So let's see, if you have a positive result, what can we optimize? Are they on optimal medical management? Is there anything that we need to change? Is there a different operation we could offer that might be more minimally invasive? And then do we need to change the level of care? So do we need to place more invasive lines? Do they need to go to a step down or ICU bed instead of just going to the regular floor? Do we need to move them from an ASC or an ambulatory surgery center to a main hospital so that, God forbid, something does happen, the cath lab is right there and things are very intervenable? And then I just can't underscore enough having this conversation. So you have to have a discussion with your patient and the surgeon. You guys, if everybody's on the same page, the finger pointing doesn't happen, because everyone's talked about what the goals are for the patient, what the risk tolerance is, and what the desired outcome is. And so if you're working on this together as kind of a triad, I think that you're able to help get the patient the results they want in the safest manner possible. So basically, if you need a stress test in the absence of surgery, you should do it. For probably 95+% of patients who are getting a stress test to quote unquote be cleared prior to surgery, you can skip it. And you really want to know what, if you are ever going to get it or ask for it, you really want to know what you're going to do with the results before you do that. So. Thank you very much.
And now, last but not least, it's Dr. Rebecca Kerlach. Let me see. And Associate Professor in Anesthesiology and Critical Care, the Director of the Perioperative Medical, or the Perioperative Medical Director, Vice Clinical Service Chief of Anesthesia, University of New Mexico. And she's going to be talking about, do I really need to get an echocardiogram, or when do I need to get it? Thank you, Rebecca.
Thank you, David, and thanks to everyone for being here on late in the meeting. So I'll be talking today about explaining the differences between a diagnostic and a screening test, which is really important when you think about any cardiac testing, but it comes into play quite a bit with getting an echo. We're going to identify places in the 2024 stepwise approach to perioperative cardiac assessment where echo is indicated. That's just the algorithm, from the 2024 ACC AHA guideline. And we'll talk a little more in depth about incorporating cardiac biomarker evaluation into your decision to obtain an echo. It kind of plays into, again, all of these cardiac topics, but it's more prominent in the 2024 guidelines, so I want to touch on that a little bit more. So firstly, let's just talk about some general principles. So really, what is a test? Why do we get preoperative testing? A screening test is basically a risk factor-based test that you get when you might have further diagnostic testing if it's abnormal. And this is generally for patients without symptoms, but you're getting the test because you have a suspicion there might be something going on. It's based on risk factors or based on, risk scoring tools or maybe some other indicators, but it's not because the patient's having active symptoms. Whereas a diagnostic test is based on specific signs or symptoms. The patient is presenting to you with a problem, you're suspicious they have an issue, and you're answering a clinical question as to whether they have or don't have a disease because of their signs or symptoms specifically, and that's a diagnostic test. And it's important to think about this with any of our cardiac testing. We're going to kind of give some examples, and we'll kind of start at the top left. Let's try to figure out which category these tests go into. So if someone is doing a stress test based on an elevated calculated risk and the fact that they can't do 4 METs, is that a screening or a diagnostic test? Exactly. What about a stress test in a patient who's having exertional chest pressure? Diagnostic, excellent. What about if we're ordering a proBNP in a patient with orthopnea? Diagnostic, right? They're having signs or symptoms and you're trying to get a diagnosis. A proBNP in a patient with an RCRI of 2? It's a screening. They just have some risk factors. What about an ECG in a patient with irregular heart rate? Diagnostic, exactly. So again, in our ECG topic, you're always going to get it. It's one of the most common reasons I get an ECG in my pre-op clinic is an irregular heart rate. What about in someone who's 85 years old, they have some risk factors, hypertension, diabetes? Screening. And then an echo in an 85-year-old with hypertension, diabetes, they're just, no one's looked at their heart and you want to get an echo because they have risk factors. Screening. And then an echo in an 85-year-old with heart failure and you suspect that they've had worsening ventricular function because they've had a maybe change in their functional status. Diagnostic. So it's really important with any of our topics this morning that if it's a diagnostic test, very often it is indicated because you are investigating signs or symptoms, regardless of whether they're actually having surgery. You probably would be getting this testing anyways. Maybe they would have gone to their PCP. You just happen to be seeing them in a preoperative clinic or pre-surgery. And it usually should be completed prior to surgery because, again, you're answering a question that we're assuming is going to change our management because they have a problem. This is, with the exception of cataracts, I would say that's pretty much always, unless they're actively having an MI in front of you, most of the time no testing is indicated at all. But more often than not, it's informing our perioperative management. When it comes to screening tests, it is true that this does often inform our risk assessment, but the question for us with an echo is an echo the best screening test if we're looking to inform our risk assessment? An echo is quite expensive, it's labor intensive, it requires an echocardiographer and a cardiologist. So even if you're ordering it for a screening reason, the question is there a better screen that isn't as labor intensive? And as a little fast forward to the end of my talk, we're going to talk about biomarkers as being a much better screening test because much less expensive, less easier on the patient, but it's where the screening idea comes in. Screening tests might be indicated prior to surgery if your results will change management. So it's not wrong to order an echo as a screening test if you think that it's going to change what you're going to do. And it ultimately may lead to further diagnostic testing, and that's where the proBNP is a really great example of a screening test that, if abnormal, often does lead to more testing, but it's a great first test before just jumping to an echo. So our take-home point for this first part is to really consider the indication for testing, whether it's screening or diagnostic, when you're deciding on whether to obtain an echo before surgery. So now let's get to the 2024 ACC AHA guidelines and look at what does it actually say and where does it indicate that an echo might be indicated. And that's one of the big differences with 2024 compared to 2014, is that it is really focusing on what cardiac testing is indicated, whether it's ECG, echo, proBNP, coronary CT, stress echo. It deals with a lot more information than just stress testing like in 2014. So we're going to just focus in a little bit on this middle box. With this box, what we're trying to do is estimate perioperative risk. So as Dr. Schaff mentioned, the risk calculators for adverse cardiovascular events are the first step in determining risk. But the guidelines actually ask us to consider whether patients have any risk modifiers. So it's again that patient who has severe pulmonary hypertension but has a low calculated risk based on RCRI. We know that the modifier, their pulmonary hypertension, is very important in driving cardiac risk. So there's several things on this list where we might be getting an echo simply just to better quantify their risk modifier, even though it's not part of our pure risk calculator RCRI ischemic cardiac disease list. So severe valvular heart disease, severe pulmonary hypertension, elevated risk congenital heart disease, these are obviously things that an echo is really critical to making the diagnosis or establishing the severity of disease. We'll come back to that in a second. The second area where this plays in is when you have determined that the patient has elevated risk, that they have a risk modifier present. And what does the box say? What do they tell us to do with that information? So this is basically where you're making this team-based decision based on the whole spectrum of risk assessment. And you'll see that echo again is mentioned. And in this case, they make it a green shaded to yellow box. So I guess depending on how strongly you feel about it, they couldn't quite decide is it green or yellow. But basically what this box is saying is that for diagnostic reasons, so if you suspect that the patient has moderate or severe valvular stenosis or regurgitation, if they have new dyspnea or suspected new or worsening ventricular function, that an echo is very likely indicated. And I'm going to call these things diagnostic because, again, there's something about your patient assessment that is indicating to you that they have the problem and you need to quantify how bad the problem is, or you need to make the diagnosis of the problem. So I'm going to say that these are all diagnostic reasons to order a preoperative echo because you're establishing the diagnosis or reassessing the current state of the problem, and you're getting a quantification of how bad things are before you get going. I'm going to mention briefly, because I get this question quite a bit in my pre-op clinic, how do I know if I suspect severe valvular disease? Maybe I knew that they had previous valvular disease. How do I know if I should be suspicious if it's now become severe? So if you have a situation, the patient had mild aortic stenosis on the echo 3 years ago, should I repeat it? What if it was moderate aortic stenosis 3 years ago? Should I repeat it? So the key question is, what is the likelihood that it's progressed in that interval to severe disease when I should be ordering the repeat echo? Not directly from the peri-op guidelines, but in the 2020 ACC AHA guideline for the management of patients with valvular heart disease, if we just look at what would the routine follow-up be for a patient who had these findings on a past echo, we can see what the cardiologist would be doing as far as following these diseases over time. So you can see that with aortic stenosis, if they have mild disease, repeating the echo every 3 to 5 years is reasonable. And same thing with mild aortic regurgitation. Every 3 to 5 years is reasonable. So if a patient had an echo 2 years ago and their AS was only mild, I don't think it's critical to repeat the echo before surgery because it's less likely that it's progressed to severe in that interval. However, you can see that if we just jump to both moderate disease, where it's every 1 to 2 years for follow-up, or severe disease, where it's every 6 to 12 months, if a patient 2 years ago had moderate aortic stenosis on the echo, it's very reasonable to repeat that now to see whether things have progressed to the severe stage. And even if a patient had severe AS last year and no one decided they needed a TAVR at that time, if it's a year later, a lot of things may have changed. And again, it's reasonable to repeat the echo, and it would be indicated based on just routine cardiology follow-up. So the guidelines do say to us, this is now from the peri-op guidelines, if the patient has suspected moderate or severe AS and they're undergoing elevated risk non-cardiac surgery, so again, they're not having their carpal tunnel, they're not having their elective hernia maybe, they're having something more significant, preoperative echo is recommended to guide perioperative management and to kind of reassess the baseline disease. And it's actually the same thing with valvular regurgitation. I know we often don't worry as much about severe regurgitation, but remember that untreated severe MR, severe aortic insufficiency, both of those things can lead to heart failure and LV dysfunction over time. So I think that's part of the concern here is in following that up to make sure they haven't kind of fallen off the curve and now developed heart failure. So our take-home point here is that preoperative echo may be indicated for the diagnosis of disease, and delaying surgery to obtain an echo is indicated if the diagnosis will guide perioperative management. And most often that's because you're having more elevated risk surgery, or you have some sort of reason to suspect that they may have more significant disease that if it's present, they may actually need like a valvular intervention or some further heart failure management or something prior to undergoing surgery. So now we'll get into the place of the guideline, which is a little bit more nuanced. And it's this whole middle section. And I'm going to take you through this pathway and talk about the steps along the way. So if we looked at patients that have elevated cardiac risk, but they have no risk modifier. So these are the straightforward people. They don't have valvular problems. They're not having pulmonary hypertension. This is just the person who you calculate based on the risk calculator that they have elevated risk. And they also, you've determined that they have poor or unknown functional capacity. You're now in, again, the screening area. You've calculated risk, they have poor exercise capacity, but there's nothing else going on that would make you automatically order an echo. So the question here is, they have elevated risk, they have poor function. In this case, they indicate you should order a biomarker. So we're going to talk about that next. And if the biomarker is abnormal, that's when you get the echo. So if you're purely ordering an echo for screening purposes, I pretty much think you should always be obtaining a cardiac biomarker, getting a proBNP, because if you can rule out the need for an echo based on a simple blood test, that's saving everyone a lot of time, effort, and expense. And I'm going to go into how to interpret proBNPs with a little bit more detail so that if you've never ordered one before, you can maybe be empowered to order and at least understand what the numbers get you. But just recognize it is the intermediary step in a screening with getting a screening echo according to our new guidelines. So which biomarkers are being referred to here? So the natriuretic peptides, it's actually a 2A recommendation for an NT-proBNP, and I'm just going to call it proBNP, or a BNP. Effectively, those two things are relatively interchangeable, but most hospitals, you either have only an option for one or the other, and proBNP is pretty common, so most places I don't think have BNP available, but if you only had BNP, just recognize the numbers and the scale are a little bit different. Most of the papers, everything refers to proBNP. Values are reported in whole numbers, so it'll be reported in picograms per mil. Normal increases with age, and this is where proBNP gets a bit muddy because it's not just a single number cutoff that you can use in order to determine risk. I'll go into some of the subtleties. But basically, it's released with increased cardiac tension, wall tension of both atria and ventricles. And that's important because you're not just saying, oh, the ventricles are stretched out because there's heart failure, the BNP's up, therefore, they definitely have heart failure. If you have chronic AFib, for example, and your atria are always a little bit stretched out, again, that can increase your proBNP. If you have, acute episodes of increased pressure, like you have a PE, that could increase your proBNP. There's a lot of things that can increase it, but all of them are not good. And so I would say it's always indicative of something. The question is whether it's indicating heart failure or something else. With high sensitivity cardiac troponin, this is a 2B recommendation. I think just based on the literature and based on what's been done as far as preoperative assessment and risk stratification, that's probably why it's a 2B. But basically, high sensitivity troponin, they're also reported in whole numbers. So unlike the old school troponins where you'd have the decimal points and you'd have to remember if it's at 0.03 or 0.3 that's significant, it's basically whole numbers. Normal, I would say, is less than 14, but there's some variation depending on the assay in your study, in your hospital, and also with male to female. For sure, less than 20 would be in the kind of more normal range. But if you start getting into the 30s, the 40s, the 50s, and certainly anything in the triple digits is very abnormal. So just recognize the numbers have to be pretty low in order to be normal. And it's released with myocardial tissue injury. So again, doesn't necessarily mean MI, but it does mean that you're having some myocardial injury. Biomarkers have been looked at as a rule-out test or as a preoperative test, and in a large population of patients who had preoperative troponins and proBNP measured, they all had CV risk factors, and they just said, let's measure the troponins, let's measure the proBNP, let's look at RCRI and see which ones do the best job with predicting outcomes. And this was in a high-risk group that were having 5% of them were having MIs within 3 days. The best predictor of post-op MI was actually stratifying people by RCRI, looking at their baseline troponin of whether it was over 14 and whether their proBNP was over 300. And that one is had the best area under the curve as far as predicting post-op MI. But also from this, we recognized that it's actually an excellent rule-out test. So if you have a troponin that was less than 14, it's a 97%, has a 97% negative predictive value for the patient's going to be fine and not have an MI. Same thing with proBNP, 96% negative predictive value, that if it's less than 300, that they're not going to have an MI. So it's actually quite useful for that, especially if you're on the fence about ordering an echo versus not. It's actually a really good rule-out test, and that's often how I use it most commonly in the pre-op clinic. So the recommendations are that it's reasonable to measure a BNP or a proBNP before surgery to supplement evaluation of perioperative risk. They do qualify in the guideline that the optimal threshold values of BNP and proBNP have not really been clearly established. So it's tough because, again, I know 300 is going to be in our mind, which is good, but there's not really a set number where we know 100% that this number is where they're going to be safe and this number is where they're not going to be. So I do want to provide a little bit of practical guidance, because if you start ordering proBNPs, you're probably going to start getting some numbers where they're high and you're like, well, now what do I do with this? Because it's not less than 300, but it's 350 or it's 400 or it's 450, and you're like, is that normal? Is it not? So to provide you with a bit of a framework, this is actually from the European Journal of Heart Failure. And if you look at what influences proBNP, age definitely influences proBNP. So if you look at a patient who's under 50, if they have a proBNP less than 300, it's very unlikely that they have heart failure. The patient who comes in with some dyspnea on exertion and you're like, I want to rule out heart failure because I want to make sure you're fine, and they're under 50 and their proBNP is like 100, they do not have heart failure. You're doing fine. However, if you look at when heart failure is likely, like what if you get the proBNP back in that patient and it is 450? Well, in a 50-year-old, that's abnormal. I think that needs investigation. That's much higher than I would expect for a 50-year-old patient. And if they came in with dyspnea and I was wondering if they had heart failure, I would definitely go down the pathway of getting an echo. But if it was the 70-year-old or 80-year-old who said they had a bit of dyspnea and they had a proBNP of 450, I'd be like, you're doing great. We don't need to do anything about it, because as you get older, a lot of people get diastolic dysfunction. A lot of people are going to have a little bit of increased wall strain, and that's actually quite normal. And if you do the echo, it's not going to be a problem. So as you get older, your proBNP cutoff has to be a lot higher. I would say I personally, honestly, anything over than 1,000, if I'm doing it as a screening test. If it's over 1,000, I do typically still order additional testing, because I'm not convinced that they don't have a cardiac issue if they're of that really advanced age. And honestly, for the people in between, you have to be a little careful with just interpreting their other risk factors. I also want to mention that you have to reduce your cutoff levels in obesity by 50%. So let's say you're doing a bariatric surgery patient, they have a BMI of 50, you can't get an echo very easily because of body habitus, and you do a proBNP. If their proBNP, let's say they were 60 years old and you get a proBNP and it's 450, 500, that's actually quite elevated, because that level is often reduced by 50%, so it's kind of equivalent to 1,000 in a non-obese person. So just recognize that obesity can falsely lower your proBNP. And lastly, it's renally cleared. So if you have an ESRD patient and you get a proBNP and it's 10,000, that happens all the time, and I'm not sure how to interpret that. There's not a lot of literature on whether that means anything at all. Is 8,000 versus 10,000 any different? I don't know. So I don't typically order them in ESRD patients. It's not a useful screening test for them. So my take-home point for this section is if preoperative NT-proBNP is normal or less than 300, an echo is likely not necessary. And just remember that normal means expected based on age, renal function, and BMI, or it falls within the patient's baseline. And with that, I will end there and we'll, I think, do a group Q&A.